is it really possible to make our eating habit change without pharmacological intervention?
Absolutely. So, two parts. One is pharmacological intervention is to it's like going and drowning in a Ganges. I mean, taking a bath in the Ganges. It is to pay for your old sins, right? It will help you bring your weight down. But ultimately, if you want to escape the clutch, but also remember, pharmacology is a subscription model. It is not a buy and forget it model. It is a SaaS. It is obesity control as a subscription. You have to pay for it for the rest of your life. But if you notice all these studies, they will tell you that when you stop the drug, your weight goes up. What they don't tell you is, there is a subset of patients who only gain weight minimally, including the surmount 3. There are people who will not gain weight. What has happened in them? They have learned the way to change their life. So after your weight is lost, you have learned a discipline to maintain weight. Why should you gain weight? But it takes an effort.
Next question is a follow-up question from him. Actually, whenever you try to start a patient on tirzepatide, the next question they ask is how long to continue. And you have said that they develop a habit after taking this to change their habits, stop eating or eat less. How long do you think you need to continue the medication to make them realize?
This was done in SURMOUNT 4 trial. When the patient stops taking the injection, what happens? Whether the patients will go on maintaining the weight loss or they are going to regain them. So in SURMOUNT 4 trial, they have clearly shown the patients were taking the tirzepatide for almost 9 months time, and one arm was continuing the drug, and some certain patients were discontinuing the treatment. And after the period of almost 12 months, that is 1 year, what they got, they regained the weight, but the regaining of weight is not very much, they are not gone to the original weight, but only 10% they reduced the weight, gained the weight. So even if you stop the drug, it almost the drug's actions was there for almost a period of 3 to 4 months time. But definitely, as such, the indication is we cannot stop the drug. We have to go on giving the drug only. If the patients are very much strict in their dietary habits and exercise program, probably we can give a trial for some time after 2 or 3 years time.
So last question.
Yes, Dr. Ravindranath, and this is a very basic questions for the benefit of the delegates, right? So non-diabetic obese patients you are giving. At the same time, this patient can have normally secreted GIP and GLP. So what will happen? See, this particular drug,
Yes.
the trial was conducted in non-diabetic obese individual on the top of naturally secreted GIP and GLP. You are giving this combination of dual agonists in high dose. What happens?
Sir, usually in even obese patient also GIP secretions was less, not only in diabetic patient, even the obese secretions also the GIP secretions goes down. It is not same as other normal persons, definitely.
Actually, if you look into this study conducted by Dr. Anup Mishra and an article published by A.K. Singh, they have clearly made a mention that in obese individuals, the DPP-4 levels are very high, they are upregulated, they are overactive. So that brings about degradation of the naturally secreted GIP or GLP. So when you give this particular dual combination, so this gets increased. Not only that, this GIP prevents internalization of the GLP that occurs inside the cell. Thereby it allows high dose of GLP to act for a long period of time. Another thing, the resultant nausea is also less in this particular combination GIP, because if you look into the area posterior as well as nucleus tractus solitarius, we have inhibitory neurons as well as excitatory neurons, and this GLP activates the excitatory neurons, so it causes vomiting. Whereas GIP that suppresses excitatory neurons and stimulates the inhibitory neurons, thereby minimizing the vomiting. So because of this, we are getting very good response with this particular.
I'm not so sure. I think one of the things that we need to understand is that the GIP action is not very well understood, because the GIP action in the mouse models are very different from humanized and human mouse models. What is more likely that is happening is one is a phenomenon called biased agonism, meaning normally when GLP acts, what it does is there is a stimulation of cyclic AMP, there is also a recruitment of beta arrestin. When in terzepatide, there is a recruitment of cyclic AMP but no recruitment of beta arrestin. The function of beta arrestin is to remove cyclic AMP from circulation and the GLP-1 from circulation. So what it does is it sort of prevents receptor desensitization. That's really what beta arrestin does. But when you give GLP-1, when you give terzepatide, what it does is it prevents beta arrestin activation. Only cyclic AMP is activated. Therefore, it pretty much behaves like a super GLP-1. Therefore, there are pharmacological levels of GLP-1, suprapharmacological levels, even higher than semaglutide that are seen. So while GIP does have some action and mostly on the fat, the majority of the action is GLP. What is probably even more important in the action of the drug is that it dissociates the dopamine centers from the opioid centers, which means that food is no longer perceived as a reward that needs to be pursued. If you look at my thing, there is a liking and there is a wanting. It prevents that wanting to happen. And that's really how these work, and that is why these drugs are now being slowly started being used in addictive disorders. So there is a link between that entire talk that I gave and what is actually happening with these drugs. This reward motivation segment is cut off. Now, to go back to the first question that Srinivasan asked, can you do it on your own? Yes, but it takes effort.
Thank you. Can we conclude this? You have a question?